Well, hello and welcome. My name is Andrew Campfield. I'm the Director of Nursing, Chief Nursing Officer at Ness County Hospital in Ness City, Kansas. And thank you for taking the time to participate in this presentation on the transfusion of blood and blood products. Through this presentation, we will identify the indications for the transfusion of blood and blood products. We will review the policies related to the transfusion of blood and blood products, and we will demonstrate in a separate skills validation session the procedures associated with the transfusion of blood and blood products. In this presentation, we will highlight these listed policies. I recommend that you have these policies available for you to review, either in the printed policy manual, in the shared drive, or in the emails, communiques that were sent to you in preparation for this training. Now you have those available to you through these training and through the skills validation and testing that we will also perform with the blood transfusion competencies. We will not cover those policies 100% as this presentation goes. Each of them are very specific and very in-depth, and you need to be familiar with those. These policies guide the process by which the administration of blood or blood products occurs, the process by which uncross-matched blood is administered, the reference guides from the AABB on transfusion reaction, and the steps by which transfusion reactions must be managed. So please make sure that you are familiar with these policies in the day-to-day conduct of your job. It is extremely important that you know the right things to do, the right steps to follow, and know where to go if you have questions relating to those things. Never assume that you know exactly what the policy says. Always refer to the policy in its actual form if you have any questions. They're always available there for you to refer to. So why would we administer a blood product? Why would we transfuse a blood product? The most common indications include the replacement of blood loss. So acute hemorrhage, be traumatic injury, be that a GI bleed, something that's causing an acute active blood loss. We could administer a blood transfusion to replace the lost blood. Correction of anemia, again, be that acute because of loss of blood, or be that chronic because of chronic illness, chronic disease. Other types of blood-related disorders, such as thrombocytopenia, could justify the use of a transfusion of blood products. In any case, the specific need will dictate what the treatment is and what type of blood product would be administered. For our organization, the most common blood transfusion that is provided is the transfusion of packed red blood cells, or RBCs, and that is generally for the correction of an anemia. By definition, anemia in men is a hemoglobin less than 13.5 grams per deciliter, and in women, less than 12 grams per deciliter. But we typically follow a more restrictive threshold for the transfusion of blood, and that is a hemoglobin level of 7. There are lots of factors that come into play with this, and the combination of blood availability, the risk of transfusion reaction, and the overall benefit to the patient, we see that the level of hemoglobin of 7 tends to be the most common evidence-supported guideline that we see. That does not mean that you would not administer a transfusion of packed cells to a patient who has a hemoglobin level of 9. Another consideration is a drop in hemoglobin of 2 grams or more in a 24-hour period. So an acute GI bleed is admitted to the facility with an initial hemoglobin level of 13, and within the next 24 hours, a redraw and a continuation of bleeding that we can see by their symptomology is present, and their hemoglobin is now down to 9. It may be appropriate in that situation to go ahead and administer a transfusion. Again, each situation will be dictated by that individual presentation and what is recommended. General rule of thumb is that administering 1 unit of packed blood cells would raise a patient's hemoglobin by 1 gram or their hematocrit by 3%. Another note to keep in mind is that in active bleeding, the administration of a blood product like a packed red blood cell transfusion does not stop bleeding. Transfusing packed cells, transfusing red blood, does not promote coagulation, does not prevent further bleeding. In fact, some research shows that transfusing blood products can increase the risk of bleeding even more. Without the transfusion of plasma, platelets, or use of whole blood, we're not providing any coagulation factors, anything that would go to replace those things that have been lost in acute hemorrhage. So transfusing blood may correct an anemia that is present, may replace volume that is present, but it will not stop active bleeding. Just something to keep in mind. So I'll take just a few moments to talk about blood products more in depth here. Most commonly at our organization, when we administer a transfusion of blood products, it is packed red blood cells. But there are more than just packed cells that can be administered. When blood is donated, that blood is separated off and spooled off and packaged into different forms. People can also donate specifically plasma. When we compile these things to the blood banks, we generally see whole blood, packed red blood cells, platelets, and plasma. We can break these things down even further, and we can actually do just white cell transfusions. We can do just platelets. We can do just plasma. We do albumin on a fairly routine setting within our organization. Albumin is actually spun out of the plasma. It is actually a blood product. Though we don't type and cross that with individuals, it is a blood product. We don't typically have to type and cross it because we're not giving the red cells, we're not giving the white cells the antigens and things that may exist should be completely removed. That being said, transfusion of albumin can lead to a transfusion-based reaction. So it is important when administering albumin to an individual that we're still monitoring them appropriately. Another thing that can be done is cryoprecipitate. So with the transfusion of blood products, whole blood is transfusing the whole thing. A unit of blood that is donated is then transfused into an individual. In the right situation, this is a very great tool, very good tool. We don't have this available at our organization, and most facilities within our area do not. So the whole blood transfusion isn't the most common thing that you will see. Packed cells is. A transfusion of packed red blood cells is pretty common for what we will see. In general, a packed red blood cell transfusion is about a 300 to 330 mil fluid volume transfusion. It is 1 unit of blood that is specifically typed and crossed for that individual or uncrossed. In the uncrossed stance, we're going to see utilization of type O, be that positive or negative blood, and I'll look more into typing here in a few more slides. The platelet transfusion is exactly what it sounds. It is transfusing just the platelets that have been separated out from that donor unit. The transfusion of plasma is just the plasma that has been separated out. So the different product will be identified based upon the need that the individual has. In any transfusion, we want to follow the same processes. We want to make sure that unless it's an uncross matched, which I'll talk about later, that it is specifically type and crossed for the person receiving it, that it has been prepared appropriately, and that it is going to be administered in the right format. We will always begin a blood transfusion with the proper informed consents and written consents being obtained, the proper IV access being established, and the infusion beginning at a slow rate and being monitored for the first 15 minutes, and then infusion rate being increased in a proper stepwise fashion after that. Depending on the transfusion, packed red blood cells, again, range from around 300 to 330 mils in volume. Platelets around 100 mil in volume. Whole blood, typically around 300 to 400 mils in volume, depending on what they've split out. Plasma, again, around 300 to 400 mils in volume. So the same process will always be followed. We're going to type and screen them appropriately. We're going to cross-match the right blood product to be given them. And then we're going to make sure that we've checked everything correctly and that the consents have been done appropriately. We initiate the infusion, and then the infusion rate would be increased in a proper stepwise fashion. So we'll do a quick recap from biology, anatomy, and physiology regarding blood typing. So when we look at blood typing, or the group that we have blood type A, B, AB, and O. This chart kind of breaks down the presence of the antigens that are on the erythrocytes. The A has the A-type antigen, the B has the B-type antigen. AB has both antigens. O has none of them. When we look at the antibodies that are present, again, that is broken down to having the anti-B antibodies in type A, the anti-A antibodies in type B, no antibodies in type AB, and both antibodies in type O. So when we look at blood types, we look specifically about the donor type and the recipient. Type A blood can donate both type A and type AB. Type B blood can donate to both type B and type AB. Type AB can donate only to type AB, and type O can donate to all. Who can they receive from? All right, so when we look at receiving blood, type A can receive blood from type A blood types or type O. Type B can receive from type B or type O, and type AB can receive from all. Type O can only receive from type O. So you may have heard the phrases of universal donor and universal recipient. So universal donor is type O. They can give to any blood type, but the universal recipient is only AB. So we can give a unit of O to any blood type. But if I'm an O blood type, you can only give me type O blood. This is when we get into type and crossing our blood types. It's a very simple thing that's done with our Coombs test, but if it's not done correctly and we give the wrong type of blood to an individual, it can cause pretty severe reactions. Now, with that being said, if a person has never had a transfusion of blood products before and you give them a transfusion of blood product, the risk of a reaction is relatively low. The more transfusions that a person has, the higher the risks of transfusion reaction exist. So the more transfusions we have given to us, the greater our risks happen with each transfusion. So we spoke about groups or blood types, A, B, O, AB. Now I want to talk about RH. RH, or the rhesus factor, is a protein that is found on the erythrocyte. If you have the protein, you're Rh positive. If you don't, you're Rh negative. The majority of people are Rh positive. That doesn't mean that we just assume that everyone is Rh positive and that they can receive it. This is why we want to type and cross, why we want to do a specific type and screen. If we administer Rh positive blood to somebody who is Rh negative, it could become harmful for that individual. So we have our four groups, A, B, AB, and O, and we have our rhesus factor or our Rh type, positive and negative. In the majority of patients that are going to receive a transfusion of blood, we will type and screen, or we will type and cross that blood specifically, and we will make sure we draw the right blood product out of the blood bank to give to that patient. But in general, Rh positive versus Rh negative. A person who has an Rh negative blood type should not receive Rh positive blood. A person who has an Rh positive blood type can receive Rh negative blood. If an uncrossed emergent transfusion is indicated for female patients, they should receive O negative blood, while a male patient can receive O positive blood. In general, women of childbearing age should not receive Rh positive blood unless they have been specifically type and screened as an Rh positive patient. Men of any age are more likely to be compatible or able to receive Rh positive blood. It is important to remember again that the majority of transfusions that we will administer will be to patients that have been appropriately typed and screened, and we will go to the blood bank and we will have the right blood pulled for them, brought to our facility, and prepared to be administered in that setting. In the event that an emergent transfusion is performed, we carry 4 units today of packed blood cells that are O, 2 units of O negative, 2 units of O positive. In the situation that we might be administering blood products to more than one individual and we don't have the ability to do the proper type and screen, and we have the emergent setting, a mass casualty situation, a multiple trauma, and we have to choose who gets what, evidence supports that most commonly men of any age should be able to safely receive Rh positive blood, so in this case O positive in this emergent setting, and women specifically of childbearing age should receive the O negative blood. So if we have a car accident and we have 2 individuals involved in the accident, both adults, men age 40, woman age 40, woman age 30, we're going to give the man the O positive and the woman the O negative. That's how we would treat them in that emergent setting. Again, the majority of cases will be type and crossed appropriately. In the event that we do not, this would be the recommendation or the considerations we would follow. At our organization, the transfusion of blood products can occur in the emergency department, in an outpatient setting, in an inpatient setting, in a skilled setting. The types of transfusions that occur are going to be specifically type and cross-matched or uncross-matched emergent transfusions. Now we're going to begin going through more directly the transfusion of blood and blood products, policy 11.01. Policy 11.01, the transfusion of blood and blood products. Scope applies to all licensed nursing staff, licensed medical staff, including MD, DO, PA, and APRNs. It is important to note as we move forward that all licensed staff able to administer blood products will complete both initial and annual education related to the transfusion of blood and blood products, including a skills checkoff. The procedure is to replace blood loss, correction of anemia, and other blood-related disorders through the administration of blood and blood products. Blood products can be administered in the following settings: emergency department, inpatient, outpatient, observation, skilled swing bed, and intermediate swing bed. Blood or blood products includes packed red blood cells or PRBCs, fresh frozen plasma or FFP, platelets, and whole blood. According to our policy and according to state licensure and the AABB guidelines, only providers or RNs are allowed to administer blood or blood products. Staff will observe universal precautions when preparing and administering blood or blood products. The use of intravenous infusion pump is preferred for the administration of blood and blood products. In certain cases, the use of a pressure bag and a gravity infusion of blood products may be necessary. The tubing used at our facility is a 20 drop per mil setup. So that means 20 drops equal 1 mil of fluid. Only normal saline is used to prime and flush blood infusion tubing. We do not use other IV solutions, D5W, D5NS, half normal saline, lactated ringers. Only normal saline is approved for use in the blood tubing. No IV medications of any type or IV fluids other than normal saline shall be infused through the same infusion site as the blood transfusion is going. It doesn't mean that you cannot use that IV site for something different before or after the transfusion, but not during the point in time that a transfusion of blood product is occurring. And again, only blood tubing is used to administer blood products. The blood tubing cannot be used to administer any other fluid or any other medications. Blood products are to be infused through the largest bore IV catheter available, preferably no smaller than a 20 gauge. If a large bore IV access is not available, initiate a new IV access with, again, preferred no smaller than a 20 gauge. If you're unable to obtain a 20 gauge catheter, a 22 gauge IV catheter site may be appropriate. Note, if you're using a smaller than 20 gauge site, the infusion rate may need to be adjusted while infusing the blood product so that we prevent the damage or the lysing of blood cells. The use of an IV fluid warmer or a blood warmer is recommended when available for the administration of blood and blood products. It is preferred that a new blood tubing set is used with each unit of blood to be transfused. It is recommended that a 170 to 200 micron filter is placed in all blood tubing that is to be used for the infusion of blood and blood products. If necessary, the same blood administration tubing and filter can be used for the infusion of back-to-back units of blood, given that they are the same blood product. So if a patient is to have 2 units of packed red blood cells, you can administer both of those units with the same tubing, giving that there is no more than 8 hours of total usage on that tubing as a whole, and that you have no more than 2 units transfused through that tubing. The tubing is not to be left hanging after it is complete. It is to be discarded in the appropriate receptacle. If administering consecutive units, you begin the initial infusion as directed, you administer the first unit, and then you, using the saline, flush the blood from the first unit out of that tubing, and then hang the second unit following through. You do not want the first unit and the second unit to be touching. You want them to be completely flushed in between. So you must flush the blood tubing in between units if you're using the same tubing set. Prior to beginning any blood transfusion, baseline vital signs must be taken on the patient. This includes temperature, pulse, blood pressure, pulse oximetry, respiration, and pain scale on either a 0 to 10 scale or an age-appropriate scale. If the baseline vital signs include that the patient's temperature is greater than 100 degrees Fahrenheit or 37.7 degrees Celsius, you do not begin the transfusion. You must notify the provider of the elevated temperature in advance. Once the unit of blood has been initiated on a patient, the registered nurse must remain at the patient bedside for the first 15 minutes of the transfusion. The RN may leave the direct bedside after the first 15 minutes, given there are no signs or symptom of transfusion type reaction present, and that the nurse must then be available to closely monitor the patient during the transfusion. The nurse will assess the patient's vital signs and document a full set of vital signs at 15 minutes after initiation, 30 minutes, 45 minutes, 75 minutes, and then every 30 minutes until the transfusion is complete. The RN will also then check and document the patient vital signs 1 hour post-transfusion. Signs and symptoms of transfusion-related adverse reactions must be monitored for during and after the transfusion of blood products. If any sign or symptom of transfusion-related reaction occur, the nurse must immediately stop the transfusion and notify the provider. The RN will refer to the blood transfusion reaction policy, policy 11.04, and the Association for Advancement of Blood and Biotherapies Quick Reference Guide 11.04b as a reference for the identification of signs and symptoms of possible transfusion-related reaction. If at any point in the transfusion process a patient develops symptoms of a transfusion-based reaction, stop the transfusion immediately. Notify the provider and laboratory staff immediately. A transfusion reaction workup must be completed on any patient that develops signs and symptoms of a potential transfusion-based reaction. Once a reaction is suspected, do not restart the transfusion. Policy Appendix 11.04b, the AABB Quick Reference Guide, is available for staff and should be available at the bedside for all transfusions as a reference guide. We will follow these recommendations and these outlines for the symptom presentation of transfusion-based reaction. Policy 11.07 is the specific policy that relates to the transfusion of uncross-matched blood. In general, it is the policy of our facility to only transfuse blood that has been specifically type and screened or type and cross-matched for the patient who is receiving it. If the provider determines that blood transfusion must occur immediately without a type and cross, the provider must document on the appropriate emergency uncross-match forms and include the clinical condition that is present that justifies administering the uncross-matched blood. If an uncross-matched transfusion is to occur, then the transfusion will be administered following the same process outlined in 11.01. The difference is that the provider is validating the need for an uncross-matched emergent transfusion. The transfusion procedure. The first thing is that we will note and verify the order from the provider. We will explain the reason for blood or blood product transfusion to the patient and obtain proper informed and written consent from the patient, their durable power of attorney, or their family. We'll contact the laboratory department to ascertain whether the type and cross-match blood is available. The appropriate screens will be obtained by the lab and the blood will be prepared. At our facility, this will mean sending the type and cross samples to our blood bank supplier in Hayes and having the proper blood selected and then transported back to our facility. We'll establish an IV site. It again is preferred to use a 20 gauge IV site at minimum. If a smaller IV site is the only thing that is obtained, we may need to adjust the infusion rate to accommodate. To gather the proper equipment that is needed for the transfusion, we will need the IV pump. We will need the blood administration tubing. It is preferred that we utilize a 250 milliliter bag of normal saline, and we have the proper standard precautions, gloves. Again, the note IV pump is preferred, but the use of gravity or a pressure bag may be necessary for the transfusion of a blood product. When the lab has the blood appropriately typed and crossed and they have received that into our blood bank, laboratory will notify the nursing staff, and the laboratory technician and the nursing staff will then need to check the blood out to have it appropriately dispensed from the blood bank and cross-checked with the patient and the blood bands. When the nurse will go to the lab to check out the blood, the checking out process will include that the lab staff and the nursing staff verify the blood product, the patient name, the patient date of birth, the patient medical record number, the donor type, the donor unit number, the date the unit expires. the patient blood type, the cross-match result, and the verification of the patient's blood band number. While verifying the unit of blood, we also need to visually inspect the blood, the bag itself, squeezing it, looking at it, looking for any hemolysis, clots, or visible abnormalities that may be present. It is important to note that all numbers on the cross-match transfusion report must match exactly with the numbers on the blood bag, and the blood must not have any bubbles, lumps, sediment, or any defects present in it before beginning the procedure. If the information is correct, the sign-out form and report must be signed by both cross-checking personnel. Lab personnel releasing the blood shall sign issued by, and the RN retrieving it will sign received by. This will include the proper date and time on the forms. It is important to make sure that we gently agitate the unit of blood to distribute the blood cells, and prior to connecting the blood to the infusion tubing, we perform the proper consents with the patient and their DPOA. It is recommended that before checking the unit of blood out from the blood bank, that you again confirm with the patient and with the patient's family and DPOA, if that's necessary, that you want the transfusion to occur. Once a unit of blood has been checked out from the blood bank to administer to a patient, it cannot be returned. There is no grace period. There is no ability to return it to the blood bank. We do not check out blood units just in case, and we must make sure that the consent has been obtained. It is either going to be administered or we do not check it out. At the bedside, 2 licensed nurses need to prepare the blood transfusion unit along with the other equipment and be able to double check it at the patient's bedside. Again, checking the blood product, patient name, patient date of birth, medical record number, donor unit and RH type, donor unit number, the date the unit expires, the patient blood type, cross-match result, and the blood band number. Just a quick recap. Again, it is important, step 1, that we confirm the orders, confirm consent has been appropriately obtained, and confirm that the proper education has been provided, including the risks and benefits of the transfusion to the individual receiving it. All these things need to be done before we check any blood out from the blood bank. Once it has been checked out, there is no returning it. Starting the transfusion. Prior to beginning transfusion, the nurse will be obtaining a baseline set of vital signs. The transfusion for an adult patient will begin at 50 mL per hour. The nurse will remain at bedside for the first 15 minutes. After 15 minutes, the nurse will reassess the patient vital signs. If no signs or symptoms of transfusion-based reaction are present, the nurse may increase the transfusion rate to 100 mL per hour. For the next 15 minutes, the transfusion rate will continue at 100 mL per hour. At 30 minutes after transfusion initiation, the nurse will reassess the patient vital signs. If the transfusion is being tolerated and there are no signs and symptoms of transfusion reaction, the nurse may increase the transfusion rate to 150 mL per hour, which is the max recommended infusion rate for a routine transfusion. If at any point in the transfusion process a patient develops sign or symptom of transfusion reaction, stop the infusion immediately. Notify the provider and notify the on-call laboratory staff. We will not reinitiate a transfusion if a reaction has been suspected. It is important to know that most reactions occur within the first 15 minutes of initiation of a blood transfusion, but they can occur at any point in time during the transfusion and even out to 24 or 48 hours after a transfusion occurs. Close monitoring of a patient must be continual. The nurse must be able to monitor the patient through the entirety of the transfusion. Couple of notes on transfusions. Once a unit of blood has been checked out, it cannot be checked back in. We will only check out a unit of blood if administering the blood is assured. Once a unit of blood is checked out, the transfusion must be completed in 4 hours. The goal is to begin a transfusion within 15 to 30 minutes of checking out the unit of blood. If initiating a transfusion within 30 minutes occurs, most transfusions will be completed within 2.5 to 3 hours. For the adult patient, the ideal transfusion rate is between 100 to 150 mils. If you check out a unit of blood and begin it within 30 minutes and reach a 100 mil per hour transfusion rate within the first 30 minutes, you will administer that blood product in 4 hours. It is important to note that some transfusions may need to occur faster than that timeline, and that is appropriate. A max rate of 150 mils may need to be exceeded in situations where a patient is suffering from acute hemorrhage and severe hypotension prior to the initiation of the blood transfusion. It may be appropriate to administer a transfusion within an hour in some cases. It is preferred to use an infusion pump to administer a unit of blood. In some situations, gravity or infusion by pressure bag may be necessary. It is also recommended that a fluid or blood warmer is used if available to administer a unit of blood. For adult patients, again, ideal infusion rates begin at 50 mils per hour and go up to 150 mils per hour. It is appropriate in some adult patients that a max transfusion rate of 100 or 125 mils per hour may be all that is necessary. For pediatric patients, the recommended transfusion volume for blood product is based on their weight. It is recommended to transfuse 10 milliliter per kilogram of body weight of a blood product. This total volume is recommended to be administered over a 3-hour period. So if your pediatric patient was 10 kilograms in weight, you would administer a 100 milliliter blood transfusion over 3 hours. That 100 milliliters divided by 3 would equal approximately 33 mils per hour. To initiate that transfusion, you would start at 25% of that max hourly volume. If that was 33 mils, you would divide that by 25, and you would begin your infusion rate at 13 mils per hour. You would increase that by that quarter over 15-minute increments to reach your maximum 33 mils per hour. Again, use of a blood warmer or fluid warmer is recommended in the infusion of blood and blood products. Again, noting that it is preferred to use an infusion pump for the transfusion of blood products. Certain situations may require the rapid transfusion of blood. Transfusion should always begin at a conservative rate for the first 15 minutes to assess for a reaction. After the first 15 minutes, if no sign or symptom of reaction are present, the infusion rate may be increased to a rate that is appropriate for the situation. For an acutely injured patient or an acutely ill patient suffering from severe hemodynamic compromise prior to the transfusion, and it is known or suspected that the anemia or blood volume loss is causing their hemodynamic state, infusion of a blood product of a rate over an hour or potentially less may be appropriate. If using gravity or a pressure bag to infuse a blood product, it is important to know that the infusion tubing that we use has a drop rate or a drip rate of 20 drops per mil. So 20 drops equals 1 mil. If calculating a gravity infusion or a pressure bag infusion, an example to follow would be that 50 drops per minute equals 150 mils per hour. So if the nurse is counting drops per minute and you counted 50 drops in the drip chamber over a minute, that would be 150 mil an hour rate. Assessing for reaction needs to occur throughout the entirety of the blood transfusion. Again, the nurse must remain at bedside for the first 15 minutes. Baseline vital signs must be obtained, and then reassessment occurs at 15 minutes from initiation, 30 minutes, at 45 minutes, at 75 minutes, and then at 30-minute intervals until the transfusion is complete. After the transfusion is complete, a minimum of a 1-hour post-transfusion reassessment must occur. We're going to take the next bit of time here to go over different transfusion reactions. The NHSN's hemovigilance module identifies 12 types of transfusion-based reactions that we will review. The general allergic reaction is the result of an interaction of an allergen with preformed antibodies. In some instances, infusion of antibodies from an atopic donor may also be involved. It may present with only mucocutaneous signs and symptoms. The list on the right here includes conjunctival edema, edema of the lips, tongue, and uvula, erythema and edema of the parietal area, generalized flushing, hypotension, localized angioedema, maculopapular rash, pruritus, respiratory distress or bronchospasm, and urticaria or hives. A probable reaction is the presence of one of these symptoms. A definitive reaction is the presence of 2 or more of these symptoms. Transfusion-associated dyspnea is respiratory distress within 24 hours of cessation of transfusion that does not meet the criteria for transfusion-associated lung injury or transfusion-associated circulatory overload or allergic reaction. Respiratory distress should not otherwise be explained by a patient's underlying or pre-existing medical condition. Febrile non-hemolytic transfusion reaction is represented by the presence of fever and or chills without hemolysis occurring in the patient during or within 4 hours of completion of a transfusion. If transfusion related, the most common cause is a reaction to the passively transfused cytokines or a reaction of recipient antibodies and leukocytes in the blood product. If the blood culture of a patient or a residual component is performed, the results should be negative. Laboratory findings should show no evidence of acute hemolysis. A hypotensive transfusion reaction is a drop in blood pressure occurring during or within 1 hour of cessation of transfusion. Other symptoms such as facial flushing, dyspnea, abdominal cramps may occur, but usually hypotension is the sole manifestation. Identifying a hypotensive transfusion reaction can be a challenging one in patients receiving blood products, given that many receiving a transfusion may already have a low blood pressure or a low volume state. It's important to note for adults that a drop in systolic blood pressure of 30 points or more from baseline could be indicative of a hypotensive transfusion reaction. For infants and children or neonates, a drop in systolic blood pressure of 25% or more would be of a great concern. If a patient's blood pressure is beginning at 80 systolic and we are administering blood products because of acute hemorrhage, that would not be considered a hypotensive transfusion reaction. So this is a shift from the baseline. When we see a shift from baseline in these points, it is recommended that we hold the transfusion and that we notify the provider and that a proper workup is done. A delayed hemolytic transfusion reaction is one in which the recipient develops antibodies to the RBC antigens in which they have received. This gets into that incompatibility, if you will. Typically, we see this between 24 hours and even possibly up to 28 days after cessation of a transfusion. Clinical signs of hemolysis are usually going to be present, and if performed, a post-transfusion blood workup could show LDH and bilirubin levels increase and then subsequently fall back to baseline in the following days. A delayed serologic transfusion reaction is one where we see a demonstration of new clinically significant alloantibodies against red blood cells between 24 hours and 28 days after receiving a blood transfusion, despite an adequate and maintained hemoglobin response. An acute hemolytic transfusion reaction is a rapid destruction of red blood cells during, immediately after, or within 24 hours after receiving a blood transfusion. Clinical signs and symptoms and laboratory signs and symptoms of hemolysis are going to be present. The list of signs and symptoms ranked out here could all be present or could be present in a cluster of 1, 2, or more. It is important that any suspected reaction, that we stop the transfusion, that we notify the laboratory staff, and that a post-transfusion or a suspected transfusion reaction workup be performed. Transfusion-associated graft versus host disease. To try to simplify GVHD, when a person receives a transfusion of a blood product, more likely in these cases it's going to be the transfusion of white cells or a bone marrow transplant, or if they've received an organ from a donor, they are at risk that the immune competent cells that have been grafted into them proliferate and then attack the host. So this is the case instead of the host rejecting the graft itself begins to attack and reject the host. So it's important, again, to remember that reactions can occur days following a transfusion, and this is more commonly going to be seen in the transfusion of white cells than it is red cells. And then one of the reasons why, again, education is so important and proper screening, crossing, and matching is so important. Post-transfusion purpura is the developing of a thrombocytopenia, usually arising 5 to 12 days following a transfusion of cellular blood components with finding of antibodies in the patient directed against the human platelet antigen system. So we start to attack our platelets, and this causes purpural or hemorrhagic type of rashes. We see a breakdown in these pictures here of the difference between petechiae and purpura. It's important to know that with purpura, what's occurring is the destruction of thrombocytes within the body, the destruction of our platelets and our clotting factors, and so this is causing small hemorrhagic type rashes. Transfusion-related acute lung injury, also known as TRALI, is an acute hypoxemia with a PO2 fraction of inspired oxygen ratio of 300 millimeters of mercury or less, combined with a chest x-ray showing bilateral infiltrates in the absence of left arterial hypertension. Example, the absence of circulatory overload. Onset of TRALI is often abrupt in association with transfusion. So we'll see hypoxemia occur, severe respiratory distress, low oxygen saturation, and other clinical evidence. This is going to be difficult for us to truly assess for here at our organization because we don't do arterial blood gases. So what we need to be identifying is acute onset respiratory distress, presence of crackles, rales in our lung sounds, lung fields, the assessment or the indication of fluid overload in their lungs, hypoxia, even the symptomology may be present of the suspecting a pulmonary embolism. So again, we want to immediately stop the transfusion, deliver high flow oxygen, notify the providers, and perform our laboratory workup. These patients may require acute treatment with CPAP and BiPAP, and more than likely even emergent transfer to another facility where they can have more aggressive care provided. Transfusion-associated circulatory overload, also known as TACO, occurs when we have an infusion of volume that cannot be effectively processed by the recipient, either because we've given them too much volume at too high of a rate, or they have some underlying symptom or compromise. Pulmonary failure, chronic congestive heart failure. The older, more frail patients can be very susceptible to this. It can occur within the time frame of transfusion if the transfusion is occurring too rapidly, and it can occur hours out after the transfusion. When we have onset of acute worsening respiratory distress, radiologic or clinical evidence of pulmonary edema, pulmonary effusion, evidence of circulatory overload, these things are of great concern. When we transfuse patients, it is not uncommon that our clientele are older, more compromised, or more frail patients. And many of you may be experienced with providers routinely ordering diuretics in order to administer a blood product. I want to clarify that it is not the standard of care and it is not recommended routine practice that diuretics be administered in the transfusion of blood products. Blood products should be administered to patients who have an anemia that is causing a symptomatic presentation. And delivering those blood products in an appropriate rate, in an appropriate manner is very important. Delivering a unit of blood and evaluating that patient through that process is very, very key. If the patients develop symptoms of overload, we need to, at minimum, be slowing down the infusion rate. I'll give you an example in which a provider orders that a more elderly, frail patient receive 2 units of packed cells. We administer 1 unit of packed cells, and the order is given to administer a dose of diuretics in between those units. Evidence today supports that we really need to consider administering 1 unit of packed cells, evaluating that patient after that unit, potentially even providing the second unit in a full day or a couple of days following. If this patient needs to have diuretic in between these units to prevent circulatory overload, the question really needs to be raised is, do they need both these units today, or do they need both of them at all? So it's very important that we assess and manage the patients individually, all in steps to prevent any potential complication. And circulatory overload, especially in an elderly and frail person, is a very common complication. I'm going to reiterate that routine administration of diuretics to prevent this so that we can administer multiple units of blood is not an appropriate treatment. Transfusion-transmitted infections. Though not very common, it can happen that an infection can occur because of a transfusion. In this, a bacteria, virus, potentially even parasite or other pathogen is transmitted to the recipient through the donated blood product. Definitive lab evidence of the pathogen in the transfusion recipient would need to be obtained for us to validate that the infection occurred because of the transfusion. So, recap on transfusion-based reactions. If at any point in time during a transfusion, any transfusion-based reaction, symptom, or sign becomes present, we stop the transfusion immediately. We manage the patient, we notify the provider. If adequate symptomology is present, we must do a complete workup. Laboratory staff needs to be notified, and a workup is to be performed according to those policies. So some common misconceptions regarding transfusions. As already mentioned, pre-medicating patients prior to transfusion is not routinely recommended. It is not appropriate to pre-medicate a patient with acetaminophen to prevent a transfusion-based febrile reaction, to administer an antihistamine like diphenhydramine to prevent a reaction. It is not recommended that we routinely administer diuretics like furosemide with a transfusion. It is not routinely recommended that we transfuse blood for hemoglobins greater than 8. And giving packed red blood cells does not stop bleeding. It is not uncommon for a person who's receiving a blood transfusion to have received them before. And I want to reiterate what I've said earlier. The more transfusions a person has received in their life, the greater the risk of transfusion reaction actually becomes, because they have had so many exposures to multiple foreign blood products and they have the potential to develop multiple antigens and antibodies. So wrapping up on our transfusion of blood products, giving blood can be a life-saving skill. It can also be a very risk-involved process. So it is extremely important that we are very knowledgeable and very versed in monitoring and assessing for blood transfusion reaction symptoms. With any of these transfusions that we do, it is always important to know your policies, to be familiar with the procedures and the steps, to have those resources available to you at all times. Provide the proper education to patients and family. Keep our providers in the loop and in the know of things that occur if there's a concern, and be able to keep lab and the blood banking staff in the know if any possible reactions or complications occur. Knowing if a blood transfusion resulted in a reaction isn't always a very easy thing. Some of these reactions are going to be identified through blood workups, through serology and through hematology, being able to look at hemolysis and incompatibility of cells. Some of them may be very aggressive and very front, right in our face. So if it doesn't look right, it's probably not right. Stop the infusion and notify the provider. Be constantly monitoring, be very vigilant with our care of our patients. I know through this presentation, again, I've been very focused and very serious. I don't want you to think that delivering blood products is something that we should avoid. It is something that, without question, we should do if it's the right thing for our patient. But I don't want us to just think it's another infusion. So thank you for your time and participating in this video. Look forward to being with you hands-on in our skills validation, going through those things and our tests. Thank you again.